Welcome to 360 Point of View, supported by Mothers of Victims Equality, Inc., also known as MOVE, Inc. We are so excited to have you joining us for episode 1. I'm one of your hosts, Lily Swansiger.
And I'm Karina Mike, your other host.
Thank you. With the release of each episode, we will also release a second version translated into Spanish by Lina Esposito. So if you would prefer to listen in Spanish, check out that release. Drawing from Karina and MOVE's mantra, we always want to give a 360 point of view for purpose out of pain. In today's episode, we will be joined by Dr. David Hendricks and Simona Carter. We are so excited to have you joining us today. So thank you for taking the time out of your busy schedules to join us today. David, would you like to start off by introducing yourself?
Sure. Thank you for having me on. My name is Dr. David Hendricks. I worked my way through college and medical school as a paramedic in the city of Bridgeport. After residency, I went into emergency medicine, and I spent the significant portion of my career as the medical director for an emergency department. And approximately 8 years ago, I had the opportunity to move into addiction medicine. And so I am boarded in both emergency medicine and addiction medicine at this time, although I only practice addiction medicine. And over the time, I've kind of had to deal with trauma both on a personal level and an experience level, and now dealing with patients as they have gone through traumas and how it's affected them long term down the road.
Great. Thank you so much for sharing. And Simona, would you introduce yourself?
Good morning. My name is Simona Carter, and I am a mom first. I work as a social work supervisor for the Department of Children and Families, and I've also worked many years in the areas of human services as well as public education. I am a 6-year parent advocate and a 22 plus year child advocate. I don't work for an agency. I just do these things on the strength of building a better community.
Great. Thank you so much. Okay, so we can get started with our questions. I have some more general questions that are regarding just basic about trauma, and then I have a couple more specific ones for each of you regarding your careers and the specific expertise that you'll have. And then hopefully Karina will join in if she has any specific questions as well.
I will.
Sounds
And
good.
thank you so much, you both, for taking out your time, as Lily stated. I'm just so grateful and excited about this episode and looking forward to what you all have to share.
Ditto, absolutely. I'm so excited. Okay, so my first question, and you guys can jump in however you would like. Would you consider yourself trauma informed? Which I'm going to guess for both of you, you would. And we did touch on it a little bit, but in what ways did you become trauma informed? Was it through personal experience, helping others, school, work, or training, media, etc.?
Would you like to tackle this one first?
Sure, I will say trauma, firsthand experience, school, working with, the community in any aspect. I do a lot of work in the community. I help out different organizations when I have the time. But when I became trauma informed, oh, sometimes I feel like I've been trauma informed all my life. We live in families that are not perfect, right? And they cope the way they have to cope during that time. I take a look at, different things that happen in my family. And I take a look at what's happening now in families. And you see how the trauma, the generational trauma has, for me, it seems like as it moved through families and it moved through generations, it has gotten worse because it's not addressed, right? And I also think, when I listen to some, people talk about trauma and DBT therapy, just from a work perspective, as also as like a community engagement, being out in the community, listening to people speak about trauma. Some people, I feel like they think that if you remove a child or a person from the trauma, that trauma is no longer there. But you have to remember they're still connected to the community. So the trauma doesn't end. It may not directly impact them, but they're still impacted by the trauma, although they're removed from the traumatic environment.
Mm-hmm.
That part. I'm sorry, Dave. She just jumped right in, right?
No. I had asked her to go first, so that was perfect. From my point of view, sorry to say, in medical school, there's very little education in trauma, or at least there was 25 years ago. Um, and even in EMS, especially in EMS, you're taught to be stoic, and you're taught to just kind of let everything just kind of roll off your back. And then in emergency medicine, especially as the physician, you're the one who has to be calm in all situations and never let anything kind of affect you. Um, so from a trauma point of view, it was really kind of learn on the job and kind of deal with it as you can. And that's really what kind of made or break people who are geared towards emergency medicine as opposed to those who aren't, because it's not that easy to kind of be able to separate yourself from that area. As for overall trauma informed, it's interesting because in my career now, we're learning so much more about trauma and how it affects people. So I feel I'm still learning what trauma informed is, because as a society, we're learning
Mhm.
that there's so much more to trauma than we ever thought before. So kind of didn't learn it then, learned it on the job, and now eventually studies are now coming out, and literature is now being written on trauma. So trying to make myself better trauma informed as more information comes out, because it really has a such an impact on society as a whole.
Yeah, and I think one of the things that you mentioned when we were speaking earlier, um, was what really stood out to me about the difference that is made, about how before we thought PTSD was just for like combat veterans, police officers, and now we're learning about almost anyone could have PTSD. And you were talking about how it's just based off how the people kind of experience it, right?
Exactly, and that's one of the key takeaways over the past 5 to 10 years, is that we're realizing that it's an individual's perception of that trauma,
Hmm.
that you and I could live through the same event and I could perceive it totally different than you, and it can affect me 20 years from now. And when I say totally fine with it, understand that it might affect you in some ways, but not to the significance that it did me and the impact that it made on me.
Hmm.
And that all goes down to the neurobiology of all this. What we know now, or what we're realizing more about, is not only, when we're talking about nature versus nurture, when we're talking about neurobiology and things like this, we're talking about both. It's nature. So, there is a genetic component. So we're predisposed to certain things, but then we need an environmental cue to kind of activate that gene or suppress it, kind of depending on what we're talking about. So there is that big role in both the genetics and the epigenetics. There's both nature and nurture together, working together in this. And because of our genetics, we could just perceive things totally differently, and has such a significant impact on our lives.
Absolutely. And I'm sorry, Karina,
Um,
I interrupted you. You had your hand up, I believe.
I did, but he expanded and expounded on what Simona had originally tapped into in her intro. And that's what I wanted to extract a little bit more, to just be able to dissect it. Because what he said, I love that nurturing nature. I love that. I use that all the time, Dr. D. I use it all the time because it is so significant in connection with talking about intersectional trauma, right? And when
Correct.
Simona, what you had did, hun, is you sat there and you helped us to see that, this isn't just intersectional as opposed to systems in daily lives, but this is generational. Simona, you had touched on, you want to expound a little bit on that a little bit more, as what you were talking about, how not addressing that trauma from, like how Dr. D has said 20 years ago, right, with a family experiencing trauma, but not really dealing with it. And then you have 20 years later, with this almost a generation and a half later, and then that trauma is still affecting that family. Can you just tap I would love for you both. I would let Simona go first on this one, Dr. D, and then you both expound a little bit more. I know, Lily, you have a lot more questions, but I just want to hone in on this for a minute because we all need to fully embrace and understand the significance of this right here, right? Because that's what it is. It's being trauma informed but healing focused, centered. So, all right, Simona.
So when I talk about, it's generational, right? We're talking about, you think about a family that has, you may perceive this family as, lazy or what have you, but you don't really know like what happened to them, like what was instilled in them as a child, right? So, you have people who grew up in the South, and in the South, um, we're just going to put it out there, the lighter, the better, right? So, the lighter you are, the less you have to do, and everybody who's darker than you have to cater to you, right? So then, that gets transferred from grandmother or grandfather to child to grandchild to great grandchild. That gets passed on, right? And in that, you see that the lighter the skin, unfortunately, in a lot of African American families, we see that, that special uncle, right? Or that special grandfather or that special cousin. That's what we would call it, right? Don't leave so and so with the special cousin or the special uncle or the special what have you, because everyone know this special person has caused some kind of harm to this child, whether physically, mentally, emotionally, or sexually, right? And so we don't address that. We just know, don't leave any children with the special whomever in this family. It never gets addressed. And years go by. And some people leave their kids with the special uncle, the grandfather, or whomever, right? And the cousin. And years down the line, you see that there's one person that had so much potential as a young child. And then as they got older, they may have start to have flashbacks and different things like that. Mm-hmm. And then they start to become an offender. Let's call it that, right? And no one addresses it. It goes unaddressed. No one talks about it. It's the family secret. No one says anything. And this goes on for generation to generation. And you try to figure out, like, why is this person in this family like this? Why is this person in the family like this? And why is this particular person in the family who has so many negative aspects about them, right? And then when you find out 22, 23 years later that the special uncle had, caused harm to this child from the time they were 5 up until the time they were 20. They never spoke a word. You never understood why, this person was considered special to that special uncle. But we all knew this special uncle had some qualities that were not good for the family. And we never discussed them. We never addressed them. We never even talked about it. And then again, like I said, years down the line, you find that, this is what's going on. This is what's happening, right? Excuse me. You find out this is what's happening. And then you start to take a look at, now these flashbacks are coming through. This once productive family member now is no longer productive. They're not paying attention to their children. They're maybe they're dressing a different way. Maybe they're you notice that they once did not drink alcohol. Now they excessively drink alcohol, and they're trying to mask these harmful memories, right? And so then you fast forward to where we are today, right? You see, like in my day, I grew up in the 70s, the 80s, and the 90s, and that's when the crack era was huge. And you see the kids and the grandkids who are product of that individual. And when you see them, they have ADHD, or they are diagnosed with PTSD, or, some kind of mental health issue, right? And so all of this comes from their parents. It could be their grandmother or their grandfather or their aunt or uncle who have unaddressed mental health issues, or their own parent that has unaddressed mental health issues that um, cause this kid to either be, negatively impacted, they're not being cared for, their mental, physical, emotional, educational, and their basic needs are not being met. And you take a look at what we have now. We have, unfortunately, a lot of kids who we see that are stealing cars and committing these crimes. When you get a chance to sit them down, they're diagnosed with ADHD, PTSD, these mirage of different mental health disorders. And when you have the time to sit down and talk to them, you find out that they were physically, mentally, sexually, emotionally harmed by someone in their family. And the first thing that they will say to you is that nobody ever talked about it. So that's when I say that this is the generation of trauma. It just progressively gets worse because it's not addressed at the beginning. In my family, we've had a lot of these different things, like every family. But the one thing my mother always told us: something's bothering you, talk about it. Talk about it so you don't get stuck. Talk about it so you don't find yourself in the same place that's, another family member you see is in the same place, So that's what I mean by that, if that helps.
Mhm.
No, it does. And that's a excellent point of view. And you bring up a lot of very good topics, and really something we were talking about the other day. You had brought up the term weathering from anthropology, and that kind of fits right in with this as well, kind of talking about a generational thing where kind of society's viewpoint and society's feelings towards a certain race or sex or whatever biodiversity we're talking about at the time, how that affects the generation in a whole host of different things, whether it be medical, like high blood pressure or congestive heart failure, psychological with increased anxiety, increased depression, increased substance use disorder. So, we know this from a pure, kind of anthropological and sociological, kind of point of view. We also can see it in studies that are being done now. We can take rats and make them genetically identical to each other. So each of their genes is identical. And one rat, we show it love. The other rat, we totally ignore. Now they get the same food, they get the same water, they get the same shelter. The only difference is the love, the petting, the hugs, whatever that one gets and the other one doesn't get.
Mhm.
And I hate to say it, but we know how to get rats addicted to opiates. So we teach them how to push a lever, and they get an injection of heroin.
Mhm.
What we know is that when these rats are continued, the rat that was shown love is a lot less likely to develop a substance use disorder to that opiate than the one who was ignored. Everything else was identical. They have the same genes, they have the same food, everything else. It's that one rat was shown love and the other one that was ignored is much more likely to become used and rely on those opiates
Yeah.
to kind of help those feelings. So we see it from an anthropological point of view, we see it from a genetic and biological point of view. So it's such multifactorial and kind of how this all happens to us.
Mhm.
And whether we're talking substance use disorder or anxiety, depression, bipolar disorder, whatever we're talking about, it's the brain trying to adapt to situations that it never should have been put in.
Yeah. And Simona, what you were saying, it reminded me a lot of some experiences that I had in school, where a lot of the quote unquote problem kids, the ones who would act up in class, who were too loud and things like that, all of my interactions with them, they were some of the nicest kids ever. They all just had like ADHD, they had problem socializing, like things like that, and people would respond like differently to them. And that really reminded me of that. And then also about the generational, my therapist actually recommended me a book called The Anxious Generation, I think, and it has to do with specifically like Gen Z and millennials and their relationship with social media and how it's affecting us. And like I don't think the human brain has evolved enough for the way that internet has evolved and the way we can communicate with each other. And it is really interesting to see the way it is like affecting people and how like we can work with that, especially with the way it changes how we are anxious and things like that. Like, should I be able to see every single person from my high school and what they're doing? Probably not. Probably not. No.
No, but also with social media, and I'm sorry to kind of jump in, but what studies are showing is that your generation is only seeing things in perfection.
Yes.
So nobody's taking and posting a picture, if they have 1 million, 2 million, 10 million followers,
Absolutely.
nobody's they're posting the perfect picture where the lighting is perfect, their angle is perfect, everything around about the picture is perfect, but that's not real life.
Yeah, absolutely.
And that it has been well studied in young men, and the societal issues that they're having now and their difficulty interacting with each other as well as members of the opposite sex, just because they expect this perfection and life isn't perfect.
Yeah. We did go off on a little bit of a tangent. I do feel like I
Yep. Sorry.
a bit. That's okay. So, David, when I first asked the other question about being trauma informed, you covered it a little bit. And one of the big questions I wanted to ask was if you found that your time in medical school or residency prepared you to work with patients who are traumatized and to help you with the stress of your career. Um, and then I think you kind of answered that it didn't really train you. And Simona, I'm also really curious about what your answer will be about how you feel your training was and the training that school staff receive regarding helping students with trauma and staff with secondary trauma. So if we want to jump into that, because I'm really curious about that.
Yeah. I can start off just by picking up kind of where I left off. So we did have some training on how to help others kind of deal with their trauma, especially giving traumatic news. So we would have case scenarios where we would sit down and role play different scenarios on how to best give bad news.
Mhm.
But at no point did we ever kind of talk about how to protect ourselves,
Mhm.
because we're the ones giving the bad news. We're the ones who are dealing with it, every day. In EMS, so back on the ambulance, after a bad call or something like that, you always had the opportunity to kind of what's called a debrief, kind of sit down with a group and discuss it and kind of let your feelings go. Um, Sorry to say, in EMS, it was kind of frowned upon because you have to be this such stoic person. Nowadays, this is changing. I'm going back a long time, but you had to be that stoic person that you're the person that can handle anything at any time. Um, and then it just kind of rolled into EMS, into the emergency department, where no matter how bad things got, you always had another patient that you had to get to, and you had to be there for that other patient. So you learn pretty quickly kind of how to compartmentalize
Mhm.
and, kind of shield yourself while everything else is kind of going on around you. And the problem there for a lot of us is it gets difficult over years to kind of let those walls down.
Yeah.
And it got to be pretty easy to kind of talking to your loved ones and still have that wall up
Mhm.
and come across very professional and very monotone as opposed to just being dad or husband or whatever. And that was very difficult, and that's nobody trains you how to do that. That's something that you kind of have to learn on your own, and if you don't, that's big consequences.
Yeah.
Simona,
So,
when you go, I wanna expand and expound on how you were how, David, you were not trained to deal with all of that. And I know Simona's going to touch on it too. So thank you.
So working in the school system and prior to that, um, I worked a lot of years in banking, but also I worked a lot in years in the human service field, and group homes and halfway houses and shelters and different things like that. And so specifically in the school system, they really don't teach you how to deal with secondary trauma, right? And they don't even teach you how to deal with the trauma that the kids face. I don't know if that has changed now, but when I was there, they didn't teach us how to deal with the traumas that the kids face, right? And so one of the things that I had to do for myself, because initially when I started working for the school system, I worked in elementary school, and that is the hardest thing to do. You would have kids that would have complete and utter meltdowns, right? And
Mm-hmm.
all I knew how to do as a mom was love these kids through these meltdowns, right? And so plenty of times I would find myself, now mind you, when I worked there, I was a truancy specialist, but I had a way with kids because I love kids. I absolutely love kids. Kids could do whatever they want. And I'll be like, well, they're just kids. But I'm also the stern one. Like, okay, you did that. We spoke about it. Now you're going to go sit down over here. Right. Or I'm going to take this away. And this is why I'm taking this away. But like I said, the first 2 years, I found myself on 90% of the time on the floor with the social worker, with the psychologist, with the school psychiatrist, psychologist on the floor trying to, work with kids and move through. And after we did that, there was never the support of, the whole school to say, okay, let's talk about this. And so what I learned to do was develop a relationship with the school social worker, the school psychologist, the special
Wow.
education department and different things like that, so that we can try to figure out like, okay, come up with a plan for this child for next time. Try to find out what's happening. And then that's when I would go into the home and say like, hey, little Johnny had a meltdown today. And once we got him to calm down, this is what he was able to articulate. And that was hard. And at the time, my son was, just getting into middle school. And so actually he was in high school. I'm old now, but and when I started working, he was middle school, getting ready to go into high school is when I started working for the school system. And I would just watch, different things and how the staff it related to these kids on a regular basis. And so, I basically took a retirement from working in banking for as long as I had, and I went to the Waterbury Public School System. It was definitely a significant sacrifice financially, but it was something I needed to do because my son was in the school with kids who had like significant trauma. And he had some learning disabilities, so those kids were in those same classes. And it was I felt like it was kind of moving him further backwards. And so I took him to counseling to find out like, okay, how do we combat this? How do we fix this so that he stays who he needs to be and keep moving? And so, a lot of people don't agree with it, but I would say to him, like, if somebody's interrupting your education, you got the right to pop them one. You really do, right? Because this is your education. And so, as I said, just going back to that, I went to, after my 2 years in elementary school, because that was so emotionally draining and you didn't get the supports from all of this every day. You had kids who were having these meltdowns and you're, calling 211 and you're doing all of this. And it didn't ever seem like it was helping them. So I went to high school. Why did I go to high school? That was like, the same kids that you see in elementary school, I got to see them come into high school just before I left. But the same issues stay there. They have a parent who's not home, one that's addicted to substances, one that has mental health issues. And then you see it morph into these kids having a more difficult time in school. When I say, why did I go to high school? I went, but I really fell in love with the kids because I saw how their trauma from elementary school and middle school, how it continued when they got into high school, right? And I've had a lot of kids commit murder. I had a lot of kids murder. I had a lot of kids become parents before they were ready to become parents and be so terrified that they would be their parent, And so when I got to high school, the school system had evolved a lot more. And so we had a lot more services for the kids, but there still was no services for the staff for this secondary trauma, right? And so one of our kids died unexpectedly, and we had an assembly. There was no one there to guide us through what we were doing with our kids at all. We basically mothered, fathered, grandma, auntie, uncle, these kids, because that's what we knew what to do with them. So we were never really trained to do that. Where I am now, we always have trainings. We always have like supports. We have like EAP to help us through traumatic situations. We actually just had a conversation with the person who runs our EAP. And what we said was that, why come weeks later? Why can't you come when the tragedy happens or when a traumatic event takes place? And so we're able to talk to them about like what we need so that we can stay kind of above ground, when we hit all these traumatic situations.
Definitely. And just for because I'm not familiar, can you clarify what AEP is?
EAP is the employee assistance program. They offer counseling supports. They offer financial supports. Like if because sometimes what we know is that when we go through these traumatic events, they show up as substance use, gambling. They show up somehow. So they offer you all of those supports. And so it's definitely beneficial. They can speak to you over the phone, or they can set up for you to get sessions in the community. They do a lot.
So going from a place where there was absolutely no support to a place that now has a lot of support, are there any things that you wish you could change or put in place at the school systems where you weren't receiving that kind of support? Like what would you want to see there?
I would want to see immediate, not just school administration talking to you, but real counseling supports there. Not just you have one social worker or two social workers in the school, but you have to remember they're dealing with that traumatic event too. So you may need to bring someone from outside of the school into the school to work with everyone, including the social worker, the psychologist, special education staff, because they're impacted by whatever has happened in that, in the school.
Yeah.
So that definitely would have been beneficial back then. Absolutely.
Thank you so much for sharing. I can keep going with questions. So one of the other big ones, in what ways have you noticed the impact of trauma or secondary trauma, especially in your day-to-day life? Don't everybody start at once.
Okay, I'll jump in. Boy, I mean that's kind of what I deal with on a day-to-day basis now. What we know is, substance use disorder, one of the biggest things that kind of cause it, to our understanding now, is some type of trauma earlier in life. And a lot of it seems to kind of come down to kind of how we regulate and how we handle stress. And we know that is not working correctly. in patients with substance use disorder. Um, and really a lot of it comes down to prior traumas. I know for me, it took a long time to kind of allow empathy back into my life, especially into my practice, because it's very easy in emergency medicine to express empathy as you're talking to patients, you're talking to families over traumatic events, things that just happened, whatever the case might be. But that empathy is almost synthetic. You because you almost can't allow yourself to feel that empathetic to that patient at a time, because you still have other patients to do. You still have your shift to finish, and you still have to come back to work. And at some point, you've got to protect yourself. So it's very easy to kind of get wrapped up in that perceived empathy and that synthetic empathy and that not real empathy while you're kind of standing behind those walls. And that takes a long time to kind of break down those walls, because we're meant to be empathetic people. We're meant to be in society. We're not meant to isolate. We're meant to be with with all members of our community, and we have to have empathy and compassion to do that.
Yeah.
And that for me was the most difficult thing, and kind of the real reason I had to leave emergency medicine, because it was really affecting how I can interact outside of work. It's very easy to kind of interact with your coworkers where everybody's on the same plane, and you all have that what we call gallows humor, and because it's kind of what we do to kind of protect ourselves, where and nobody is really letting them their real selves show, because you're all hidden behind these walls. So it's easy to kind of be in that community, but that's not your whole life. You have, in my case, a wife to come home to, kids to come home to, dogs to come home to, and you kind of have to be there for them as well. So that's really why, for me, I was blessed to find addiction medicine. I find it fascinating, not only for the science behind it and all we're learning, but also practicing addiction medicine really allows me to open up my empathy and really sit and communicate with patients and really try and touch them on an empathetic level, because there is so much that they're going through. This isn't the 70s where, hey, you're done with the physical dependency, you should be off that substance now.
Right.
That's not how it works. That is not how it works at all. Getting somebody off the physical dependency part is the easy part of my job. It's all the mental dependency. That's where the real work comes in, and that you have to be able to kind of have that empathetic connection with your patients. If that answered your question, Lily. If not, I just kind of blabbered for a long time. But
No, it definitely answered my question. Thank you.
You not only answered the question, but that helped to piece together what we have been kind of underliningly, if that's a word, talk about, which is dealing with that healing aspect of the trauma, right? Being able to take all of which you have been taught or not taught and what you have experienced, and being able to identify that on a personal level, and then being able to work, walk, and live yourself through it, right? Even if it's from firsthand exposure to trauma, or the secondary, in which both of you have tapped on it on both aspects, right? And that's why it's so good to have this full 360. And I'm not doing that as a shameless plug, but it so encapsulates why we're here. We wanted to start doing this, right? To get that full range of view, from the personal to the interpersonal to the personal, professional perspective, right? Because it does, like Simona said, and you touched on it, Dr. D, as well. I hope you don't mind me calling you Dr. D.
Not at all.
Touched on it as well. Is that, you know, you have to, it's hard to turn it off, right? It's hard to turn it off from work to home, home to work. And there's really no in between, right? That in between cool down period that we would all need when we're dealing with trauma or secondary trauma. And that's why I'm so appreciative of what you had just said, Dr. D, and what Simona has said too. You guys said it in two different ways, but it meant the same thing in my mind, is that, you know, what we're not taught, we have to learn. And when we have to learn it on our own, it's harder because you have to turn off what you've been professionally taught, what you've been educated to do, right? And then you have to sit up there and say, well, this contradicts with my personal, right? So my question to the both of you is, and I know Lily had touched on it when she asked Miss Simona what would she change in the public school systems or in the systems in which she has already dealt with. And thank you so much, Miss Simona, for highlighting that these are multiple systems, which is something we talked about, right? In which we continue to talk about the intersectionalization of trauma. Thank you for highlighting that, how difficult or what you all would change, and if there are difficulties that you see in the present day that you thought that maybe might not have been there before, in trying to introduce this line of thinking, trauma focused but healing centered.
Simona, why don't I let you answer this first? And
Mm,
I just
What
kind of
was
went off.
That's okay. What was the question again? Because I was trying to formulate my answer.
So the question again is, taking in lieu of all of what you and Dr. D had stated about not being professionally or educationally prepared for that secondary trauma, seeing it in your work environment. And again, like I said, thank you so much for highlighting the intersectionalization of that trauma, how it transcends it translates from one system to another system to another system. How how would you, and Lily had asked it about how it affected you and what you would like to see different in these different systems of what that trauma, what that information would have looked like if you had been more trauma focused and healing centered back then as opposed to now. And not just what it would look like now and why are there barriers now, but what's the barriers that you see now that you probably would not have seen back then? Because Dr. D had said, you know, well, this is what we learned. You had stated this is what they told us. And when you both were talking, it seemed like there was a little bit um naiveness, or not enough information, let me put it that way, out there about how trauma is so intersectional, right? How trauma can be translated, and how as professionals we're almost expected to be able to deal with it, leave it there, and then go home, and then go home and then come back and deal with it again. um Now, with the way in which the systems are being more open-minded and more aware of the intersectionalization of trauma, are there more barriers now? I should say, are there more barriers now with that as opposed to in the past? And if there are, how would you be able, how would you see that playing out now and how to fix it? I guess that's what I'm trying to say. I had to fix up my question because I thought about it and I'm like, wait a minute, because there probably was more barriers back then than it's now, right? Because of not being so aware and
Mhm.
so open-minded as we are as a society today, right? So with that awareness factor today, how how is it still barriers intersystem playing and intersectionalizing the support that is needed, not just for those that you work for or work to support, but for yourself and those that you work with.
If you want me to be 100% honest, and we're not here to talk
Absolutely.
about this, politicians,
Absolutely. I want you to be
medical,
100% honest, please.
politicians,
Mm,
healthcare, money.
mm-hmm,
I believe all of those things continue to be a barrier, right? Um, we know this didn't just automatically become important to society as a whole, right?
Right, right.
Something had to happen to say, oh, this was really real when people were talking about it before.
mm-hmm,
Um, Secondary trauma, urban trauma, trauma itself is not brand new. It's just more coming to the light because of all of the things that we're seeing that are happening, right? So let's
Right.
take Waterbury, for instance. We have places that provide mental health services for our community, right? But these services are oversaturated, right? Not only is it oversaturated, it's
Simona, wait a
understaffed.
minute, Simona. Wait a minute,
Mm-hmm.
Miss Simona. Let's go back a minute now. I want you, can you just, because I don't want you to lose your thought, but I want you to say a little bit more of what you mean by oversaturated, please.
So when I say oversaturated, right? So we have, I think, two in Waterbury that are our biggest providers, right? And so whenever someone has an issue, they're directed, a mental health issue, they're directed to either, we'll call it A and B, right? And so when things are happening, we're funneling all these referrals, no matter where it's coming from, whether it's school, the hospital, um, community action agencies, where no matter what, we're utilizing these two, A and B, to provide mental health services for. And because we see people every day, it's kids, it's entire families that require mental health services or addiction services or whatever, they're
Right,
being
right,
directed to these same, two places.
mm-hmm,
And so what happens is they, 9 times out of 10, you call to get services and they're like, oh, we have a 6 to 8 week waiting period, right? Because everybody is utilizing these supports. And say someone is, scheduled for appointment, but they miss their appointment frequently every day, right? Or every time they're scheduled to be seen. They
right, right,
can't close out that individual because that individual really needs the service. And they're very mindful that any point in time, this person can have a crisis. And so, because everybody is directed to A and B for services, and even if someone is not showing up, they still have to keep that case open for whatever the
right,
period of
right,
time. So when I say
right,
it's oversaturated, we have so many people in Waterbury who require mental health services, whether they're being voluntold or they're going voluntarily, right? Because of, stress and trauma don't show up just Monday through Friday, 8 to 5, right? It shows up every day. And so when I say
right,
it's
right,
oversaturated, we just don't have enough psychiatrists, clinicians, therapists, and different things like that to help the people who need the help and to appropriately help the people that are seeking help, right? And so when I say it's oversaturated, that's exactly what I mean. That is a huge barrier. Um, and even though, like I'll give you for instance, I went to get a service and they gave me a list of providers, right? And I'm calling them and I'm like, hey, they're like, what kind of insurance do you have? And I'm saying, this is it. They were like, oh, we just exited the network. I go to the next one. 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 I'm 6 people deep before I find someone that says, yes, I'm accepting it right now, but next month I may be out of the network. And so when I say insurance, the providers that we have, these are the barriers that I see. I do see that we have up and coming, mental health specialists and different things, but no one knows about them. And the only way I may know about them is because it may be someone I know, or I could be somewhere and they're like, oh, hey, I'm new in town. I'm accepting this. This is the insurance I accept, whatever, whatever. And so now you have another option for this person who may need it. It could be a family member. It could be anybody who just, someone on the street. I met some lady, she was just like, I'm just so tired and I'm just so hurt and I'm struggling. And I just met a young lady at my son's soccer. Her son's plays soccer with my son. And she said, hey, I'm new in town and I'm accepting this insurance. And I had the card with me and I gave it to her. You know what I mean?
Right.
And so these are the things that I'm talking about. So when I'm saying, and I'm not coming from it from what I do for work, I'm coming from it as someone in the community who wants to build a strong community, because we know with strong families, we have a strong community. With strong communities, we have strong families.
Right. No, thank you so much, Simona. I really wanted to stop you on that because I knew you had a lot to say on that one because we talked about it plenty of times. But I want to get Dr. D because I've seen Dr. D, his head was there for a minute there. So Dr. D, tell me how that plays out, that question plays out for you.
Yeah, no, I thought Simona brought up a lot of very good points. The other big barrier that I see and I deal with all the time is the stigma. The stigma associated with mental health, the stigma associated with substance use disorder, the
Come on
the
now.
verbiage that we use, until people realize that this is a true illness. It's like suffering from high blood pressure or diabetes or heart disease. We need people to kind of understand that we're talking on the same level. So there is nothing wrong with going to see a therapist. There is nothing wrong with reaching out for help for substance use disorder. There's nothing wrong with taking medications to help you along those, whether it be an antidepressant, something for anxiety, or a medication to help you stay off whatever substance you might be addicted to. It's breaking down that stigma that is so difficult. It's so difficult even trying to convince my patients that, hey, we don't use those words anymore because we want to break the stigma.
Right.
I have a tough time with them, and now to try and bring it into the general population. But we're talking about a disease that's a chronic illness. And it's just like kidney disease, diabetes, high blood pressure. It is something that's there, and it's something that we should be able to talk about, and it is not something that we should be ashamed of. And that's the biggest thing that I see. Talking about the barriers, there are so many barriers. Simona, you hit the nail on the head when you said money. At the end of the day, money is a huge issue. Just to have the finances to support all of this. I think my personal opinion, I've had this discussion with Lily, is about the only good thing that came out of COVID was the advent of telemedicine and kind of, the US government kind of easing up on the restriction on telemedicine, because it allowed us to bring help to so many more people than ever had access to it before. But we need to keep expanding on that. And Simona, you were so right with insurance companies. I'm not even going to get on a soapbox about insurance companies. I'm a physician, so you can tell what kind of soapbox.
Don't you do that? So don't you back off of your preaching right now? You better get back on that box.
No, just with I mean, it all comes down to finances. It all comes down to finances, you know, and as you said, with politicians, not only backing it and helping support it, but also at the end of the day, kind of helping with what's called tort law, you know, with malpractice cases and things like that. And I'm not saying physicians are physicians, therapists, you know, we're not perfect. There's we're not, we're human, you know, so we make mistakes and we should be held accountable when we do make mistakes. But
Right.
the fear that's kind of in a lot of our minds when we talk about a patient who might be suicidal or having thoughts of, you know, suicidal ideations, and what do we do with them, and you know, we're not only worried about the patient, but we're worried about, you know, potentially getting it wrong.
Getting food. Hmm.
Yeah, and getting sued at the end of the day. So, you
Right.
know, it's so multifactorial and so many different barriers, you know, and then medications that are prescribed, the patients have to be able to afford them. You
Come
know, and
on now.
that's also that's also a huge thing, you know, the cost of medications.
Mhm.
But for me, my biggest thing, the hill I want to die on is the stigma. We've got to get rid of the stigma, and this podcast is an excellent way to start to break down those barriers. And I'm not just saying that as a plug that you guys had me on, and I'm very honored that you guys have asked me to be on this. But podcasts like this that are getting the word out there that this is a chronic illness, it's a chronic disease, and there's nothing wrong with it. And let's figure out a way to help each other figure out a way to work through it. That
Yeah.
it's nothing to hide behind. It's nothing to be ashamed of. It's that we all need help, and let's figure out a way to help each other.
Mhm.
Shoot, Lily, he sat up there and went to court. He started singing the gospel right there at the end. Thank you
Absolutely.
so much. I appreciate the two of you expanding and expounding on that. I know you know, and again, I know you know it's not shameless plugs, but you're absolutely right, Doc. It's getting the word out there in a way that's going to be absorbed, right? In a way that can be easily digestible for all of us, because this is heavy and that stigmatization is real, right? And so being able to utilize this space to be able to do that, and that's why I said, Simona, get as real as you need to get, because we're at the end, you know, like I said, Doc struck up the choir when he said we are all by, you know, affected by this. We all have to understand at the end of the day, we are humans helping humans, and we all are affected in some form or fashion, and that's why we want to express and continue to emphasize the point of being not just trauma focused, healing centered, right? You have to know how to deal with it yourself in real time, like being able to deal with it right then and there. I know I'm stepping back a little bit, Doc, and I probably monopolized a little more time than I should, but I want to just hone in on the part that you had stated when you had said, you know, we didn't know how, we didn't have the proper education to be able to do it. But once I did know how, once I started seeing from another perspective that I had to work on me, right? That I had to do this, I had to find a way to heal me to be able to help the people I'm trying to heal. Right, that is so vitally important. And Simona, you know, when you said, "Look, you know, I deal with this on a daily. I'm in the community. I see the hurt. You know, I'm not just working with my own hurts, but I'm working with the hurts that I see." You asked sicker today, right, Simona? And you had someone where you was like, "Oh my God, let me whip this out and tell her." But then you come home and you got to digest that and be like, "Geez, you know, at any given moment in time," and that's what we need to understand, at any given moment in time, how intersectional, how just intertwined in our lives trauma really is, right? And trauma don't have to be that punch in your face kind of trauma. It could just be like we're stating, emphasizing here secondary trauma, right? Just the trauma of knowing that someone else is going through, and then you got to be there to help them, and you don't necessarily have to be there to help them with point by point A, point B, point C, but like what Simona did, just whipping out a card, but then having to come home and try to process the fact that, wow, this woman's child is here in a program with my child, and she, she's going through, and it's like we're all one step away, right? We're all just one step away, or one step from in our healing process, right? So it's just so vitally important, and that's why I wanted to touch in on. Thank you for talking about the politicians, talking about the money, talking about your Diane Hill, Dr. D, of stigmatism, right? But these are we grin and we kind of joke on it, but it's so real. It is so real, and being able to have this atmosphere, and being able to have our young people. Now I am going to do this shameless plug, because I do have to let everyone know that sees this. Lily is 20 years old. She's 20 years old, and she's a sophomore at UConn.
Junior.
And this is
Sorry.
Junior.
When I started junior, she said, no, I earned my junior. So, but she's a junior at UConn. And if you missed our introductory episode of who we are, who I am, who Lily is, I just want to just emphasize, and I probably will say it throughout every episode, that we even got a young woman here who's 20 years old, still in college, a junior in college. She understands the importance of getting out the awareness, the educate, proper awareness, proper education, and proper way of destigmatizing trauma, destigmatizing domestic violence, destigmatizing intimate partner violence, destigmatizing getting help, therapeutic help, proper help. All these destigmatizations, and really honing in on the intersectionalization of trauma. So I'm not stopping it, because I know we got more to go. But I just wanted to just say that thank you so much. I want to pass the collection plate. We're taking donations for Dr. D's time. He sure just brought us to church. And Simona, I'm so grateful that you brought that up and brought it to our attention. So, Pastor Simona, thank you so much for your sermon as well.
Thank you,
And I
guys.
just wanted to, say one more thing, just based on what you were just saying, Corinna, is that, I love the fact, and this is what's great about this podcast and podcasts like this, is we have to be willing to talk about it, because it's there and it affects all of us. We have to be able to talk about it. As a quick thing, knock on wood, I've never suffered from depression or anything like that. And I remember being in the emergency department, and patients would come in, oh, I'm so depressed, and your original thing is, oh, it's such a beautiful day, all you have to do is get up and go for a walk, and that's going to help your depression. Oh, bullshit, if you'll pardon the expression. I don't know if this is a over 18 podcast or not. If not, just bleep it out. But it's that's not how that is not how it works, and it's going to take education on people who don't understand that illness, that it is an illness, and it's not just as simple as just throwing a switch, and just being open and honest and being able to have that conversation. That's huge. So I commend you on this podcast, because it's much needed.
Thank you. Okay. I'm gonna skip through a little bit of the questions just because we have been chatting a lot, and I'm sure we're gonna chat more with all the other questions. But one of the big ones that I wanted to ask is there anything you have noticed about trauma and its impact that you feel isn't spoken about enough?
Since I went last, Simone, why don't you jump in?
Just that there's basically no quick fix, and even if you remove someone from the traumatic environment, it doesn't go away. I think that gets missed a lot, and I see that being missed a lot.
Yeah.
I will jump on that same thing. That was you know, my answer exactly.
Okay.
Just removing somebody from that situation doesn't mean that the trauma's there. It's imprinted on the brain, and it's going to affect the majority of actions and how you respond to certain actions for years to come, and until you kind of deal with that and work through it and figure out how to change everything. That's the only way to change your reaction to whatever action is there.
And this might be me misunderstanding, but David, would you say that that is similar to how addiction works as well? That even taking away the things, it's still left there?
Oh yeah, we yeah, that's what's fascinating about addiction medicine as we kind of understand it now. Substances of abuse, and it doesn't even have to be a chemical. It could be gambling, sex, internet, shopping, you know, whatever. Through the oldest portion of our brain in the risk reward pathway, a certain area called the nucleus accumbens, and then kind of where it goes out from there.
Mhm.
Our whole risk reward pathway, if we were to break it down to its simplest terms, is a dopamine release. Dopamine is your right now pleasurable neurotransmitter, the chemical in your brain that causes nerves to talk to each other. So dopamine is the one that we're talking about. So if you think way back to our pre-mammalian days, and there staring across a clearing was this big red fruit, and you knew that you wanted to eat that,
Mhm.
is it worth the risk to go out into that clearing to go get it, knowing that there's predators out there that could eat you? And it causes that dopamine surge, and that's what would tell us that if our dopamine level got up high enough, then that it was worth it to take that risk to go get that reward.
Mhm.
Substances of abuse, and again, doesn't have to be chemical, hijack that whole system. So instead of a dopamine surge like this, we're getting a dopamine surge up to 14 times higher.
Mhm.
So that just kind of overrides everything. And then that oldest portion of our brain then goes down to, you know, the amygdala, where emotions kind of happen,
Mhm.
and then go to another area of our brain, the prefrontal cortex, kind of in the front here, and that's where we process emotions.
Right.
And so that whole risk reward pathway is hijacked now by these substances, and we don't know how to really process emotions. And the same thing happens with trauma,
Mhm.
because we don't really know how to process those emotions and that traumatic response. And you know, we could get into the stress hormone of cortisol and its levels, and how chronically elevated cortisol levels kind of cause, you know, your brain to what's called downregulate or get rid of the receptors that could respond to that cortisol. And cortisol is important to the body, so then the body gets all out of whack and it doesn't really know what to do. And eventually what happens is you don't know how to respond to stress.
Right.
And trauma is a huge thing that causes that.
Mhm.
And so the only thing that we know is to numb that emotion.
Right.
So we don't want to have that emotion, so we numb it, and we numb it in whatever way we can. And that's, you know, a big proponent to substance abuse disorder, because you're using these substances so you don't have to feel that emotion.
Yeah. Thank you. Okay.
I know, Simona had touched on that
Mhm.
as well with dealing with the generational traumas,
Mhm.
right? When she talked about then you have that special auntie or special uncle who's an alcoholic, or who's gone to drugs, or then it trickles down, 10, 15, 20 years later, and you have a family member that came from the essence of that special auntie or uncle, and having all of those nuances of their trauma now infused or in them, their own DNA, and then they're having gambling issues or alcohol issues or drug issues. It's not just and I love the way you broke it down, Dr. D. Thank you. It's not just that that makeup or that chemical dependency now, right? Or that wanting of that chemical dependence, but now it's in your DNA to try and suppress those emotions, suppress that trauma. And so now you're looking for ways to try and do that. And you know, the only way to do that is diverting it to going and giving you some distractive type of negative or negatorial type of ways in which to do that, which would be that drug and alcohol. So thank you for bringing forth that connection and also bringing up, revisiting what Simona had stated earlier. I appreciate.
You're welcome. And I just want to kind of jump in, just going back to that hill that I'm going to die on. We no longer call them alcoholics because that has a negative connotation. Alcohol use disorder. They have the disease of alcohol use disorder. We don't even call it abuse. It's just because we really want to signify that this is a true disorder. It's a medical illness. So I apologize. I just wanted to bring that up.
Good. You talked about, no. Please correct me because again, again, that stigmatization, right? And
Yep.
and these debunks that this is what we're here for, to debunk, destigmatize, and also like you had said before too, Dr. D, changing that verbiage, right? Changing the language, which will change the lens of how we perceive, we perceive and we accept, right? And being able to process. So no, please, by all means, and I apologize for anyone out there for me misspeaking, but as Dr. D had stated, these illnesses, because they all are that, and Simona had touched on that as well. These all are illnesses. Even dealing with trauma is an illness, right? So we do have to remember the verbiage or language, and so as to keep the perception in the way in which it should be on the issues at hand, and not the stigmatizations that have been ensued in times past. So no, thank you so much for that.
Yes, thank you. So one of my next questions, and this one can be very broad, or if you have like a specific thing you want to share about it, is I feel like it's a kind of that you can go either way. But like what can you share about regarding different types of trauma treatments, or like different treatments that you've heard of, even like not necessarily a treatment, but like books, free resources, videos, anything like that, and go for it.
I could talk about this for a while. So Simona, do you want to go first? Just
So I've heard of, trauma informed, treatment, DBT treatment, and I still never really understood the difference, right? Because from what I've seen is the people that I've seen do it, have this specialty under their belt. And from people who have participated in these trauma-focused therapies, they said it's no different than just regular therapy. And the one thing that I definitely would like to speak to is like when I speak to teenagers about trauma therapy, what they always say, and this is like a lot of the kids that I speak to, they're like, I'd rather just have regular therapy and address what is happening to me now as opposed to what happened to me before.
Mm-hmm.
And so when I say, well, sometimes you got to deal with what happened before so you understand what's happening to you now. And they're just like, no, I just want to deal with what's happening right now so I can move forward better.
Right.
And maybe when I can deal with what I'm in right now, maybe later I can go backwards. Mm-hmm. And so they've said that they've expressed this to their therapist, and they're just like, nope, this is where we have to start. So I really don't understand a lot of that, but I just try to advocate for kids who say that, just like, listen, this is what they're saying. Like, is there any way that we can kind of shift this model? It just seems like the trauma focused therapy or DBT therapy. It seems like it's very rigid
Yeah.
and not kind of what the kids are saying that they need.
Mhm.
And that's just from what I'm hearing, not anything that I know of firsthand.
Yeah, and it almost sounds like a lot of the times it's like you have to get out of the survival mode of dealing with whatever you're dealing with right now, especially if it's really difficult, before you can even approach processing things like that.
Mhm.
But David, if you'd like
Yeah,
to.
that's yeah, that's very true. I do want to say at the end of the day, really what we're kind of dealing with is there's an action that occurs out in the environment. There's something that happens to us, we hear, we see, whatever. And then there's our response to that action. But in between those two is our belief systems and our perception. So we visualize, hear something, whatever, out in the environment, and then our response to it all goes through how we visualize or how we perceive that action. And that is all based on our past experiences. And this is where trauma really kind of comes in and plays a big role, because of that traumatic event, our perception is a little bit skewed, which means our output, our response to that action is going to be a little bit skewed. So in treatment, what we're trying to do is we're trying to retrain that perception to give ourselves a different way to think about that. So
Mhm.
when that action occurs out in the environment, our response is going to be 100% different, because our perception of that has now changed, our belief systems. And there's multiple different ways that you can kind of attack that, through, of course, when we're talking therapy, motivational interviewing, cognitive behavioral therapy, dialectical behavioral therapy, and all these are just different ways to kind of get to the heart of the illness itself. And whether it be very goal directed, um or just kind of through communication and kind of ask tell ask type questioning. um just as we educate, we're trying to give a different viewpoint on how to kind of look at things.
Right.
We could go a step farther and now start to talk about EMDR, which is eye movement desensitization and reprocessing. I had to look it up. I know the acronym. I had to look it up exactly what it stands for, but since I don't do it, but that is, and again, I don't really understand the neurobiology behind it.
Mhm.
Just from the point of view that when thinking about a thing or watching a certain video or something, as you get your eyes to move, it causes kind of a bihemispherical shift in your brain, kind of as it has to move from the right side to the left side. And that kind of really somehow, and I don't really know how, retrains the brain on how to think about especially the past traumatic experiences.
Mhm.
EMDR is the big one out there right now to kind of help with prior trauma. EMDR is something that takes a little while, and you have to have a therapist who's well trained in it and kind of know how to talk you through it. Um, Other ones, neurobiofeedback is a fancy way of saying that you wear this monitor that actually monitors your brain waves, and we know multiple different brain waves. And as you're listening to a sound or watching a video or something like that, and as you concentrate on that, you're trying to regulate your brain waves and kind of how you focus in on one thing and stop the scattering of the signal and all that other stuff. And then the machine, if the signal starts to scatter, and scatter is such a bad term, it goes from alpha waves to beta waves, but the machine lets you know and gives you a signal that, hey, wait, oh, wait, I gotta kind of refocus here.
Yeah.
And through that, you slowly retrain your brain on kind of how to deal with these different experiences. And then if you start to get into the psychedelics or the ketamine or things like that, which at the end of the day kind of lower your inhibition and allow kind of hallucinations to get in. The literature's all over the place on them. at the end of the day, you would need a very qualified therapist
Mhm.
out there to really guide you through that. And my personal thing, I've never experienced it. I've never done it. I've never practiced it. Never even sat in on a session while a patient was having one. But from my opinion, and take this if you will, or throw it away totally. But it's really all geared. If you have a good therapist, you're going to have a good outcome.
Mhm.
If you have just a therapist who, oh, I read about it in a magazine, then you really need somebody to be able to guide you through all that, to have the proper outcome.
Absolutely. All right. Thank you so much. And I do think that that might be all of the time we have for questions today. But if you guys would be willing, we would love to do a follow-up with a couple of my other questions. And I know Karina wants to introduce a video that we've watched before for training, that has to do with mindfulness. So Karina, if you want to introduce that, and then later on, I'll link it in the end of the video, the end of the podcast.
Okay, so I'm gonna ask Lily if she can share with you too, the video that I utilize for supporters training, called mindfulness. Dr. D, you and I talked about it a little bit, the other day when we spoke. Simone, I'm not sure if excuse me, if you've been introduced to mindfulness at all, but essentially what it talks about is what we like to emphasize, what I've been emphasizing and teaching my team is that it's having you giving you the ability to deal with your traumas, toxicities, whatever is happening that's negative in your life in real time in that moment. So being able to de-escalate before anything gets escalated is the key in mindfulness. I'd like to say, I keep putting in different people into this aspect because it's kind of difficult for multiple people to be able to produce one thing. But when we're talking about therapeutic care, the different things that are out there with chakra, Hinduism, all of these things that are meditation based. If you think about it, chakra, Wicca, Hinduism, meditation, if they all got together, mindfulness would be their baby. And so I love it because, excuse me, it does not skew away from being trauma focused, but it does hone in on being healing centered. And that's what I feel for me is one of the, thank you, Doc, is one of the proper ways in which for all of us to be able to deal with our day-to-day traumas, our day-to-day toxicities, our day-to-day environments that produce traumas or toxicities, or the people that we're helping to deal with these traumas and toxicities. It keeps us, Doc, I remember you saying, excuse me, and Simona, you as well said this thing that, you were taught about the traumas, you were taught how to guide someone else through it, but you weren't taught how to encompass it or process it for yourself. So with mindfulness, that's what it does. But you were taught to put a pin in it and then put it in and then you deal with it later, right? Or that's what you weren't even taught that educational wise. You taught that yourself to be able to internalize. And so with mindfulness, it's saying yes, you do want to be able to process it within your own self, not internalizing where you're suppressing, but internalizing where you're taking all of that negativity and turning it into a positive response. So now you don't have that traumatic response, you have a positive response to a traumatic or toxic situation.
1000%. I'm sorry. I just want to, I couldn't agree more. Of course, I'm a trained Western physician. Eastern medicine's been around for 5,000 years. They've got to be doing something right, but mind, body, spirit is what it really all comes down to. There have been multiple studies that meditation will decrease high blood pressure. Acupuncture really works for smoking, works with substance use disorder, works with chronic back pain, works with high blood pressure, even works with some heart disease. Yeah, I mean, there's, yoga kind of really kind of helps rebalance that cortisol that we were talking about earlier. All that plays a huge role in all of this. So couldn't agree more.
Thank you so much. Okay, so I feel like we had a really good discussion today. I'm very excited about this being our first episode. I just have a couple of like housekeeping things. So, um, as an reminder, we hope to include a segment of each episode where audience members can send us any questions or share their experiences. If you're interested, please contact us at our email 360povpod@gmail.com or call and leave us a message on our Google Voice number at 203-680-8557. And both of these will also be linked in the description and at the end of the video if you're watching on YouTube. Any messages we receive, the sender will remain anonymous, and if there are any names included, we will change them for privacy reasons. If you're interested in sponsoring our podcast and having an ad in our episodes, you can reach us at our email or any of the social media we will have plugged at the end of the episode. Today was episode 1 of 360 Point of View, and we covered a lot of topics about trauma, and we learned a lot about addiction medicine, which was really cool. And we talked to David Hendricks, Dr. David Hendricks and Simona Carter. So I hope that you're excited by our first episode and you'll join us for the next one. If you enjoyed this episode and would like to continue tuning in, we would love if you would subscribe, leave us a review, or follow us on social media. And if you're interested in being a guest or volunteer for 360 Point of View, you can reach us at our email or any of our social media. So for social media, we're on Facebook and Instagram as Mothers of Victims Equality Inc. And MOVE's website is move-inc.org. Each episode is going to be uploaded to Spotify and YouTube, where you can find us as 360 POV. So also, as we mentioned at the beginning of the episode, each future episode and this one will also be released translated into Spanish. So if you'd prefer to listen to that, you can check that out in all the same places that this is uploaded. We'd like to thank everyone for tuning in, especially Lena Esposito for translating, Karina Martin for my co-host, and especially Dr. David Hendricks and Simona Carter, because we would not have been able to do this episode without them. So, thank you so much.
Thank you guys for having us on. It was a lot of fun.
Thank you. This was great.
All right. So
Thank you so much.
Thank you. I hope everyone has a really nice day.